Hello, everyone. Welcome in. We are going to wait just a few seconds to allow more people to enter the Zoom. We will start very soon. Hello, everyone. Welcome to the February 2026 PQA Quality Forum Webinar. I am Melody Evans, one of the Executive Fellows at PQA, and I'll be your host. Today, our topic is From Barriers to Better Outcomes, the Value of Community Health Workers. Before we get started with the webinar, I would like to give us just a few housekeeping items. First, please submit your questions during the presentation utilizing the Q&A feature that's at the bottom of your screen. We will answer as many questions as we have time for. Also, the webinar recording and slide deck will be available to PQA members within about a week from today's webinar. You can find these resources in the Member Resources Library section of our website. We will also post the recording on our YouTube channel. Lastly, I would like to encourage all attendees to complete a quick 1-minute survey that will appear at the end of the webinar. So now that we have our housekeeping items out of the way, it is my honor to introduce our presenters. Tammy Malm, Director of Education at PQA, will open up our webinar with an overview of the PQA Social Determinants of Health Resource Guide Companion. Following her, Kim J will come and share her experiences and initiatives that demonstrate how community health workers can be integrated into the pharmacy workflow. With that, Tammy, the floor is yours.
Awesome. Thanks, Melody. There we go. So the PQA SDOH Resource Guide has 3 editions, the most recent of which details 40 projects where groups tackled one or more health-related social need. The guide groups the projects by setting, so community pharmacy, health plan, etc., and describes how the SDOH barrier that the group targeted, as well as their methods and outcomes for that particular project. PQA's work focuses on SDOH because addressing these factors is important to advancing medication use quality and helping individuals achieve good outcomes. And because of that, we are excited to publish the Social Determinants of Health Resource Companion Guide, which is, as its name suggests, a companion to the SDOH Resource Guide. At the very beginning of the Resource Guide, there is a section that highlights the common themes amongst these projects, and the number one theme is collaborative community partnerships. So we collected feedback after every publication of the SDOH Resource Guide. And people often are asking the same thing. Can you tell me more about these partnerships? So we developed the companion guide, which describes key attributes of groups that have implemented SDOH interventions with a partner group. Highlighting the partnerships in their own companion guide, especially the skills needed to be successful, felt like the best way to talk about the importance of collaboration amongst groups. Through many interviews with these partners, we were able to group the characteristics into 2 buckets: strategic approaches and supporting attributes. The strategic approaches are some of those hard skills, those tangible checkbox type skills that will help guide partnerships toward success. Examples detailed in the companion guide include assembling a diverse and skilled team and defining what success looks like. The supporting attributes are more like those soft skills, those things that are harder to measure but equally important. For example, groups being aligned on the mission and being able to adapt as the project progresses are also highlighted here. There are 10 skills discussed in the companion guide, but it should also be noted that there are a dozen other skills that could be added to this list, and it still would not cover all the skills that these groups had. Furthermore, having all of these skills within a partnership is a great way to get started, but it is not necessarily the only path to success. These were the skills that our partner groups highlighted the most often, and we felt were critically important to their SDOH initiatives. Another common question is, how do we get started? And unfortunately, the answer is I have no direct answer. But there are a few things that will definitely get you going in the right direction. First and foremost, the group needs a champion, a person that can hold the mission steady while navigating challenges and resistance. An SDOH champion needs to be a good communicator, also a person that is persistent and passionate about the health-related social need that is being addressed. They do not need to put their clinical work second, but rather stay focused on the path forward and trust that their diverse and skilled team can carry that project down the path. Which brings me to having a diverse skill set is a must. Consider someone with communications expertise, transportation expertise, navigating community resources expertise, but also food, medications, housing, insurance, billing. The list could go on and on. But having subject matter experts across the spectrum of subjects that your project will encounter will ensure that the project can move forward. Of course, when considering your team, don't forget about the pharmacist. Integrating screens into workflow is what pharmacists have been doing for decades. How pharmacists interact with patients and learn about their health-related social needs, whether formally or informally, has occurred at the pharmacy counter for forever. It's happened across a variety of concerns and a variety of disease states. Of course, formalizing a screening for the pharmacist or the pharmacy technician does allow for a more detailed understanding of the patient's barriers to care and could be added to a variety of steps in any pharmacy's particular workflow. At the end of the day, pharmacists are embedded in the community and they are an important member of the team. But I need to underscore that pharmacists cannot be in this alone. It is important that pharmacists are brought on as a partner in tackling your health-related social need, but because they have spent years building trust within the community and are often the first line of care when patients have a health concern. And whether it's a pharmacist or the partner, it is important to use local health data. You can use claims data, community assessments, whatever it may be, you need to identify the most pressing and solvable needs. With a data-informed decision about which health-related social need to tackle, it will be easier to gain buy-in and then secure human and financial resources. Last, start with the end in mind. This old trope exists for a reason. Know where your project wants to land. Know what it means to be successful. Define that. Know what metrics will keep the project alive and serving your community for several years to come. The guide also, of course, emphasizes the importance of partnerships, whether it be between a community-based organization and a food pantry, or a pharmacist and a provider, or a national health plan and a nonprofit. The partnership strengthens all initiatives highlighted in the companion guide. Across the guide, there is enormous variation in how SDOH programs are developed and implemented. And that is driven by the local nature of SDOH barriers and, of course, the unique resources that are available to each group in order to address their particular health-related social needs. Effective SDOH work is fluid, it is nimble, and it is responsive to the evolving environment and their community's needs. Of course, it is also important to find groups within the community that have established trust with the community members, like the pharmacist, the food pantry, anyone that will have the ability to continue that ongoing conversation with community members that they established years ago. It is also worth considering partnering with groups that have the financial and human resources to get the project off the ground. Obviously, the project can't go anywhere without the people and the money to do so. Thank you for listening to the work that PQA put out in 2025. And with that, I will hand this over to Kim, who's going to tell us all about community health workers and where their place in pharmacy could be. Kim?
Thank you so much, Tammy, for that. And then laying the foundation regarding the SDOH guide, because it really, really, really speaks volumes to how you support community through that lens. And using the pharmacy perspective is spot on with what collaboration does look like. So I just want to talk about those partnerships and from barriers to better outcomes and speak to the value of community health workers in this space. But what I want to do first is to ground us in that knowledge and just to say, I'm sorry about that, what, okay, ground us in that information and really talk about community health workers. So let me just speak to that. Community, according to the American Public Health Association, community health workers are foundational members of the community. They have a strong knowledge, a strong understanding of what communities need and how to connect and build trust. It's that relationship that helps to facilitate relationships with the organizations that they work for. Much of what they see in community can be supported by what their organizations provide, but community members have a bit of resistance to that process. But as a community health worker, understanding the needs and the social determinants that exist, they are able to build a bridge to conversations and to services that help to support our community members effectively and our patients. So, with that definition, it is again here that speaks volumes to how linkages to care are key in ensuring that folks have the services that they need and the access that is available to them. So, as we speak about some of the things that happen with the patient, and I don't know if it's me or guys or not, but my slides are jumping a bit. Oh, here we are. Okay, so some of the challenges that we have in patient and medical relationships are a lot of barriers that are outlined here. One being cost and access. Another one, just understanding what's being shared with you regarding your condition and even competing priorities. When we talk about those cost barriers, families are making choices about what takes priority. Do I pay the bills? Do I buy shoes or do I buy medications? And that is, again, a pause to what people choose in order to stay healthy or to bring their degree of health rather than doing what is best for their medical situation. And then with health literacy and understanding, some of the things that I've seen in my space as a community health worker is about understanding what my instructions are. What are my marching orders regarding my conditions? What does twice a day mean? And understanding that life is happening in simultaneous rhythm with what the requirements or the ask is concerning your health. I want you to think about that and add in the trust. So, from our perspective in working in the field with our patients and our clients, we understand that there is a mistrust between the medical care system and communities. It is attached to historical injustices and also stories carried from person to person about their personal experience, which leaks into community and becomes a collective standoff for the medical care. And understanding that I don't feel well in my body and I feel a sense of hopelessness and a sense of, will I ever get better? And when you think about the relationships that help to build a trust and repair those challenges, I want you to think about the community health worker because, again, to the true definition, they have a strong understanding of what the community needs and very often share the same complexities to the communities that they're serving. So when they go to advocate, they advocate with intention. They advocate on purpose to make sure that the services that are needed, they are provided with a trusting face that understands, looks like them, and shares in a way that people get it. So when we think about some of the pushback or some of the challenges that happen in healthcare and how people navigate that space, it's not about being non-compliant. It's about what do I have access to? Who is there to help me understand? And who is going to give me the insight in a way that I need so that I can achieve a quality of health that my life is asking for? So we want to, again, figure out what do great partnerships look like in this space to make sure that the person at the center, who is that client or our patient, has what they need. And we want to address that in this space. So you think about these three realms, the pharmacist, the CHWs, and the patients. And we heard Tammy earlier talk about addressing the social determinants of health. That's the space where CHWs do the most impactful work, because what they do is make sure that the life happenings that are going on do not affect the health happenings that need to exist. So when we have all of the partners operating in their area of excellence, collectively, we support the patient that's at the center. So finding the right medications or addressing that this is the space that the client or the patient is having their challenge in, they can't afford the medication. Then the pharmacist is saying, you know what, we actually have a discount program that can support that. And at the end of that, the patient has exactly what they need. And it's not a guessing game, but it's precise. And then understanding that much of the disconnect in literacy and understanding is about what does the prescription bottle say? As a CHW, I've seen firsthand going into home visits where a patient will have medication just sitting on the table, untouched, still in the pharmacy bag. And I will ask them, why haven't we taken the medicine? I don't understand what those directions or those instructions mean for me. So, taking those same understandings and even sharing that with the pharmacy as a partner is a way to alleviate some of those disconnects. So, when the patient leaves the space of picking up medication, they absolutely know how to use it when they are in their home environments. And that allows patients to build trust in both those spaces. So, again, if we're operating in our areas of excellence or our area of expertise, we can align how care is given to the patient. We can align our conversations so we're not working siloed, but we're working in synchronicity. We're synergized together. Knowing what issues exist in community beforehand gets us prepared to support them at the end game. So, knowing that it's complicated to get prescriptions or it's complicated to get the food. I don't understand how to make that connection on the patient level. But when the partners are working together, we can help address those gaps. So again, the patient who is at the center has the full support of what they need, and also the trust is being built, and they have a space where they can go to that they know help exists. So when we are talking about those trusting relationships and that gaps that we feel, we understand that when we are operating in this area of trust building, understanding the social determinants, we are able to do the things that are necessary to make sure that the person at the center, which is our patient, is taken care of. So just understanding it takes effective partnerships, understanding the common need to reach the common goal, and that's supporting patient through these different stages of support. At the core, when we are working collectively and collaboratively as a team, we do understand that the education is clearer, the barriers to are addressed, trust is strengthened, and the support continues. And having effective understandings of those social determinants also leads to the support that our patients do need. With that, I say thank you. And I yield the floor to Melody.
Wow, Kim. Wow. Thank you so much. That was very informative. You did an awesome job. Before we move into the discussion, I want to pause to remind our attendees to submit any questions that you have for Kim utilizing the Q&A feature that is at the bottom of your screen. We will answer as many questions as we have time for. So, Kim, you told us why we need community health workers, but what is your why? I feel like I can speak for everyone. I felt the passion through the screen. So, how does your personal why continue to show up in the work that you do today?
Melody, thank you so much for asking that question. I will have to answer my why, I have to come in full transparency. I came into community in public health about 15 years ago, and the door that I came through was because of my own asthma diagnosis. I had someone who came to my home and shared knowledge with me, and that was such an impactful moment in my life that I never forgot it. So when I got to the point that my job laid me off after 10 years of service, my community members like, there's a job posting, Kim, I think you'd be phenomenal for, right? And I'm like, community health work, I've never heard of that. What is that? And so I went to the interview, I got the training, I got acclimated to the asthma area I was focused in, and I was like, I'm prepared to do the work, right? But when I got to do my first home visit, I was in shock because I did not believe some of the things that were existing in my neighbors that lived doors down. And for a moment, I was taken back. I'm like, I don't know if I can handle this because this is a lot. But I had a very amazing colleague who was already hired and doing the work before me. And I went back and told her, I said, actually, I'm going to resign. I can't do this work. No. But she looked at me and she said, Kim, the reason why you're needed is because of what you saw. And it changed my perspective. And the moment my perspective flipped, I was like, okay, we need to make a difference. So as I began to help community members and I saw some of the smallest interventions make the hugest impact, I'm like, I know what I'm supposed to do. And I've been doing it 14 years later. So I just feel honored to serve because I know community members are impacted because of the lack of trust, because of the lack of connectivity, or the lack of resources that look like them. And being able to be a conduit and see that change lives has been my purpose, my motivation, my driver.
Thank you for sharing that. I really resonate with the home visits. When I was in pharmacy school, I did that with the nurse practitioner, and it's one thing to read about it and hear about it, the struggles patients go through, but to actually be in their homes and see how they're living, and it's just really eye-opening. Like I see why now you have to decide between your medication or food in your refrigerator. So I appreciate you sharing that perspective with us today.
Absolutely. And if I could just add, Melody, we used to go, the physicians used to travel with us too, to our home visits. And what was really shocking to them when they were prescribed a medication, they would wonder, why is the patient coming back with these same conditions or not getting better? And what they found out is that the home environment was a catalyst to that, or that um, they're thinking of that I explained it correctly, was misunderstood by the patient on their part. Say, for instance, someone was taught how to use insulin by using an orange as to show the strength of it, but the person thought they were supposed to put the insulin in the orange and then eat the orange. So it just caused so many disconnects. But to see that real firsthand
Mhm.
allowed them to shift how they shared knowledge, how they explained things, so that the patients were fully equipped to take care of themselves once they left those 4 walls.
Wow. So as we talk about these barriers, right, could you explain a little bit how community health workers have uncovered these barriers that might not have never surfaced during a traditional pharmacy or clinical encounter?
Absolutely. So again, a lot of the things that keep patients in a space of being unwell is what's happening in their home. And again, I came through the public health field through through the asthma lens. And when I did my home visits, a part of what I did was inspections around the house, just do observations. And a lot of things were happening was mold. a lot of mold that was happening, or people utilizing cleaning products, that would exacerbate their asthma. And a lot of things that came with that was shame. So one family in particular, both children had asthma, and the mom did not understand why the daughters remained sick. When I went to the home, I walked in and I felt the floor a little tacky, right? I'm like, this is a moisture issue. And I'm just doing my visual observations. And I asked her, as a part of me evaluating the home, may I look under the rug? And the rug was black, sticky, wet. And she said, I didn't know how to address this. I was afraid if I reported something, I would lose my apartment, right? But this was the main cause of this family having these asthma exacerbations, and even their well-being being under attack, because black mold affects everyone. But once I help her mitigate the mold removal and getting her floorboards replaced, she gave me the most heartfelt letter to say, I didn't know what I was going to do, and how the shame of what I was going through kept me from addressing my children's well-being. She said, but now that that's gone, she said, I feel like a fog has lifted. I don't have that shame. I'm not embarrassed. And now I can take care of my family. But a lot of what goes on in those homes that people will not share, about pests, about rodents, about even being unhoused. So we found that we find a lot of those things by building those trusting relationships and seeing it firsthand.
Yes, no, speaking on like those feelings of embarrassment and also loneliness, we are seeing that loneliness is becoming recognized as a driver of health behavior that affects confidence, motivation, and even consistency. And as you know, Kim, pharmacy teams right now, we're a little stretched, right? So how can we implement community health workers without adding, burden to our already stretched pharmacy teams, to ensure that patients will receive the ongoing human connection that they need to stay engaged in their health?
That's an absolutely beautiful um, question. And the answer to that can be multifaceted, right? We know that these partnerships already exist organically in the clinic. We know that because many of the community health workers who support patients, we do help navigate in the pharmacy space, making sure prescriptions are there and things are understood. So when you think about the pharmacy in itself as this space of where people ask all the questions, but they just don't have capacity. If we can leverage the relationships that we have with our clinical partners, with our CHW partners, it will make this relationship and the burden of trying to deal with it all on the pharmacy level a little less heavy. Understanding that the invitation, I feel like, needs to be there to say, we welcome you to be in this space. Please feel free to share this knowledge so we understand, because the doctors, the clinicians, everybody appreciates knowing the inside story to what's going on with patient care, because nobody wants to see their patient back in clinic 10, 15 days after they've just been seen. What is the disconnect? So as we share what the disconnect is, we make sure that all the partners that are involved understand and lean on me for that information, because I'm here for that. We're making calls. We identify ourselves as CHW supporting a patient. Understand that that's a part of this diverse team that is taking care of this patient. So the invitation to say, let's share, is, I believe, a component that's really needed to know that it's welcome in that space.
Yeah, so after that invitation is given, right, how do we frame the value to our pharmacy leaders who may be focused on outcomes and costs so we can have those community health workers integrated into our team?
So the return on investment, I really think that's the bottom line. Like, why do I need these people in my space? Because it is a cost-saving mechanism for all that are involved. When we have folks who are compliant with what the medical aspect of their care looks like, we get them in getting their prescriptions picked up. We get them in being consistent with taking their medications and understanding that what happens in this arena of sharing that we need to have understanding of why people are not being compliant. And non-compliance means they don't come to the pharmacy. Non-compliance means they're not taking medication. But if we have this partnership aligned with knowing that having community health workers attached, or even having pharmacists having that community health worker training will allow them to support motivational interviewing, culture humility, having those relationship building conversations that allow patients to remain consistent, and then the cost savings of being connected to their care medically is always a plus. It is factual, it's documented, and the research is out there to support it.
Yeah, so speaking of training, could you talk a little bit about what training is required to become a CHW, or what resources you recommend for someone who's just, starting out and would like to learn a little bit more about the work?
So currently in Illinois, there's a couple of pathways that are happening right now. We have a core skills training, which is a comprehensive 40-hour training, which is steeped in the C3 core competencies, which are designed to give community health workers all the skill sets that they need to do the work that is laid before them, be it supporting oncology patients, asthma patients, any chronic diseases, and having the skill sets that they need to do that. We are leaning now as a state toward certification, and the certification training is 100 hours. And with that, you're able to be billed through Medicaid. And a lot of organizations are embracing that approach because it does provide stability for their employees, but also it's a profitable component to have. So if someone comes to me right now, we have a core skills training that's 40 hours. You are able to take that training, get that foundational work, understanding and you can be identified as a community health worker. And then when certification is applicable in Illinois, you can take that same certificate, apply for certification, and be given the opportunity to be certified with a few additional components added.
Oh. So I know we're speaking about community health workers in the sense of pharmacy. So going on with that, have you heard of any technicians being trained as CHWs? Is that something that you would recommend for us to do?
Absolutely. So, technicians within our own organization at Sinai Chicago have gone through core skills training, and it was deemed like an additional skill set to have. So when you encounter patients, you already come with the mindset there's a why behind them. Why are they even here at the hospital? Why are they even here at this counter picking up medications? And having that understanding already there allows you to even have a deeper conversation just to ask, not do you understand how to take the medication, but share with me your understanding of taking the medication. So when they walk away, they have a clear idea of what is being asked of them in taking medication and being compliant, or just walking away with, do you understand? They say yes, and then they absolutely have no idea. So having, we call it being dually qualified or duly prepared. I think any discipline having a CHW background is a positive for how they navigate their spaces with their patients, because it gives you the insight to ask more to get to the why.
Absolutely. So what if someone is like, I'm not ready to go through that training right now to become a CHW? What can they do as a civilian to help the elderly or those who are disabled? How can they assist with breaking down these barriers?
Absolutely. So again, it's all about having that cultural competency and cultural humility regarding that. So, number one, helping those seniors navigate the spaces of asking those questions, those clarifying questions, those open-ended questions that get more than just a yes or no, going with them to spaces, helping them to understand what this process does look like so they're not intimidated, offering them different options to even get their medication, setting them up on a delivery program that helps them to be better prepared to be in control of their health care and taking their medication. And again, being a partner with them in this work in this process to ensure that they understand it. So when they don't have you as a resource, they know how to do it independently for themselves.
Absolutely. You kind of touched on this just a little bit, but pivoting away from community pharmacy, how can other healthcare organizations, including payers or health systems or even life sciences, utilize CHWs?
I really would encourage before any programs are uplifted that touch community members, that they should include community health workers in the conversation. The reason why I say that is because they bring the boots on the ground observation of what's happening in the community, so that your idea of what you feel may work, you can vet that through their experience to make sure that your approach is appropriate for what the communities need. A lot of times we'll do the research and it'll point to a particular avenue of help or support. But when we absolutely implement it, it's not quite the right fit. But if we include them at the table within these conversations, it can help shape the appropriate outreach for that community. And when it comes to payers, understanding that having a community health worker attached to your programs is a huge return on investment. We know for every dollar spent employing a community health workers, there's an $8 savings on the back end. They're not uh, an, uh, a duplication of work. They're a complement to the work that is being done, and they bring a time element with them in that regard. So, where you can say, here's the prescription, I'll see you back in 2 weeks, the community health worker can pick up from there and validate and verify that that patient understands everything that's been told to them. So, when they leave that space, they are ready to take care of their health and take charge of their health. So the partnerships, the collaborations work. We cannot do it by ourselves.
Wow, I love how you highlighted how much savings CHWs are bringing. And it's kind of like you already knew what I wanted to ask you next with duplication of work. In your slides, I like how you outlined the challenge and then what pharmacies can do to address that challenge, but also a CHW. So when we are collaborating, what do we do to ensure that a duplication of efforts doesn't occur? How do we make sure that this person stays in their lane and this person stays in their lane?
It's having collaborative conversations, inviting all to the table to say, this is your area of expertise, this is yours, this is mine, and we're going to support each other in this arena. Again, as a physician working top of their degree, they don't have a lot of time, but the community health worker has time to do that. As we were working with social workers and in the emergency department, they absolutely appreciate having that additional support, because when there's a roadblock to sharing clearly what's happening, the doctors may not be able to get through, but the CHW very well could, because of the relationships that they have with community, the connections, and the trust that they've already built. And it helps to get to the why. I've seen it happen in real time. Being in working in the ED, understanding that my patient was in there that I was seeing in home visits. I'm like, why are you back here? And the doctor, I said, can I speak to the doctor that's supporting him? And the doctor said, thankfully they recognize us a part of the team. He said, well, why are you here, Kim? I said, well, you see this patient here? Did they tell you that they had a cat? And being an asthmatic, that's not ideal. He said, no, he didn't tell me that. But he told me in a trusting environment. But it wasn't something I didn't share with that physician that would complicate or compromise his care, but improve the approach. So instead of giving him a higher dose of medication, we just addressed the cat. That was the issue with the exacerbations. So
Wow.
knowing that we all have a part to play, and having that understanding and relationships is powerful to how the patient achieves the quality of health.
Okay. So I think we're going to land with one more final question for you, Kim. We talked about the training and some resources, but where can we go to find requirements to become a CHW in our state that we live in?
Well, I would always direct you to our Illinois CHW Association that you can visit via the web. And also, there's a National Association of Community Health Workers, of which I am co-chair. There's details there. And then hyperlocal, if you're interested in going through a CHW training, please, please, please reach out to me at our CHW Center for Research Outcomes and Workforce Development, CROWD, over here. And we can give you the details that you need that are specific to your organization, because sometimes you just need a little of this, a little of that to be complete and cohesive in how you care for them. We can help you with those decisions and what that does look like for your organizations specifically.
Thank you so much. I think I learned a lot. I know our attendees there as well. So with that, I would also like to thank you guys for your questions. We did get a lot, and I'm sorry we couldn't get to all of them. But with a few minutes left in today's webinar, we'll close with just a couple of announcements. Thank you so much, Kim.
Absolutely. Thank you for having me.
Thank you so much, Tammy, as well. All right, so the 2026 PQA annual meeting will be located in Baltimore, Maryland. It will take place from May 12th through May 14th and will feature emerging trends in medication use quality, including developments in Medicare Part D and other CMS quality programs, advances in medication management services, and what's next in data interoperability. Registration is open for the annual meeting. You can use the link in the chat to register. Go ahead and block off your calendar. Let everyone know that you'll be celebrating with PQA in Baltimore, Maryland, as this also is our 20th anniversary. If you have any questions about the annual meeting, email meetings@pqa.org. Now, before we kick off the annual meeting, we will host a live CE. This is our medication use quality CE. This event will happen on Tuesday, May 12th from 8 a.m. to noon. This session target audience is those who are new to quality, so maybe even some students, and those who are somewhat familiar with healthcare quality and the landscape of medication use quality, but would like to deepen their knowledge. Pharmacists can earn 4 hours of live CE by attending, and the link to register for this pre-meeting session is also in the chat. Thank you all so much for joining us. Don't forget to complete the webinar survey if you have 1 minute to spare, and I hope you all have a great day.